Hello, everybody. So this is section 2B, day 3, and today we have Jaedon Avey, patterns of healthcare use and mortality after Alzheimer's disease or related dementia diagnosis among Alaska Native patients, results of a cluster analysis in a tribal healthcare setting. And then after Dr. Avey, we'll hear from Sarah Buckingham, elder-led programming to support cultural identity development and behavioral health among Alaska Native University students, preliminary outcomes from a randomized controlled trial. And Dr. Avey, go ahead.
Thank you. So I'm here and I'm presenting as also with Chris, who's going to be doing the first half of the presentation, but we're excited to talk with you today about these clusters that we found in service utilization. So Krista, I'll let you explain the background and I'll pick it up in methods.
Great. Welcome all, and thank you so much for your interest in attending our presentation. We're really excited to hear your questions and comments afterwards. So my name is Krista. I moved to Alaska and started working at South Central Foundation 5 years ago, and I currently live and work on the unceded land of the Tanana peoples. A reference and acknowledgement that I want to make as we start our presentation and our results sharing from Native research led and done all within our Indigenous community in South Central. So here's South Central Foundation's mission and vision for a healthy and to create wellness for all of our communities. And this project's purpose was to characterize the healthcare use among our customer owners or patients who have Alzheimer's disease or related dementia, which I'll probably call ADRD, all on the Alaska Native Medical Center campus in Anchorage. And today we hope to describe recently identified patterns of healthcare use and how those patterns are associated with different outcomes like mortality among those with ADRD. So this all started a while ago, and the background information to set the stage for this is that Alaska Native and American Indian people are living longer than they ever have before. And as people live longer, there are diseases that are much more prevalent later in age. And some of those are like dementia related. And so with an increase in ADRD, we also see an increase in the healthcare services that are used. And this could be for many reasons. Some are acute reasons, and that could be something like a fall. And some are more chronic reasons, like I am forgetting to take my medications as they're prescribed and have more chronic health issues because it's harder to control. And for us, this is really important because our leaders at South Central Foundation really want to improve detection and management of Alzheimer's disease and related dementias to better improve the quality of life of our elders and decrease the associated health events. So we did a preliminary study, and it was really focused on, well, what services were being used. So this graph below depicts some of the services: emergency department, inpatient hospitalizations, behavioral health services, and home health outreach. And what you see here is that on the x-axis, 0 is the year that a person was diagnosed, and the negative numbers are the years prior to that diagnosis. And those years are important because ADRD is progressive. So it's not like right when you get ADRD, it's diagnosed. You know, it usually progresses a little bit to become more apparent and then is diagnosed. So we care about those prior years and then the years after. So how is the connection to care? So what we saw was in the year of their ADRD diagnosis, all the services really peaked. And that was especially accentuated in the emergency room or urgent care. And then after getting that diagnosis, All of the services and how they were used plateaued, but you can see the emergency services remained higher than prior to that ADRD diagnosis, and the other services plateaued and were similar to prior. So what this did and didn't do is it did not identify which people would have the highest healthcare services. So who were those people creating those peaks or having the ED remain high afterwards? And if any of the differences in service use would be associated with negative health outcomes like mortality. And this would be really valuable, as you can all imagine, to our clinicians and our policymakers, really by identifying patients that may benefit from specific interventions based on their services being used, all to just improve our care for our elders.
So I think this is where I'm picking it up. That was a lot of the preliminary work that kind of led to this current effort. And we revised the case definition a little bit to those 55 or older, Alaskan American Indian residing in Anchorage area, and they had to have a diagnosis from SCF or ANTHC of a host of different both ICD-9 and ICD-10 codes. I will say, this will be cleaning up the codes so far. Parkinson's disease dementia wasn't included in our codes, for example, but we got most of the codes, and it leaves room for next time. We collected a variety of information from EHR, from the EHR, and it was done in a de-identified way, but it included demographic information. That was like marital status, their living situation, age, gender, whatnot. We had clinical comorbidities, whether they had diabetes or hypertension, diagnoses. It's not a comorbidity, but a related symptom of like memory problems that were diagnosed separate from the dementia diagnosis, that sort of stuff. Then we had service utilization, the services that kind of Krista described, and then some additional services, including surgery, cardiology, and neurology as specialty care visits. So we kind of expanded the services that we looked at a little bit here. So I think you can go on to the next one. So overall, the study design was a retrospective analysis of this cohort of 491 individuals from January 2012 to December 2018. And they were all diagnosed with an Alzheimer's disease-related dementia diagnosis. We did a cluster analysis to identify patterns of healthcare use, and then this Poisson regression to estimate relative risk of mortality among the members of the clusters. So this is, in my mind, this is the most useful chart of our study so far. When our statistician came back with this, because we had all sorts of visualizations that were not very helpful for describing the clusters and seeing them. But essentially what we have is 5 clusters. So before I launch into exactly these 5 clusters, I'm going to say previously our administration had kind of seen 2 clusters. They had seen people that needed to be seen like right now, and it was very clear that there had been a dramatic change in their health status. And then people who concerned family and friends had started to see a slow progression. And there was really no different, or there was only those 2 differences. And oftentimes it was basically primary care or the emergency department or urgent care. But here what we have is Z-scores. So there's like a standard deviation amongst all the services that were provided. The members of these clusters, these 5 clusters, had either less services in a particular type or more in a particular type. So if it's less, if it's on the low side. So we had all low as a cluster, all high as a cluster, and I'm going to come back to these: high primary care and specialty care, high specialty care, and then high ED and urgent care. And so what we saw is that it wasn't really like you're either coming to the primary care a lot or the ER a lot, but that there's these 5 clusters. And the clusters themselves, they really indicate a lot of differences in service utilization. So there are some that are larger, but and I think the ends are on the next slide, but the ends are on the next slide. But I think if you stick with the current slide, I just want to, this idea that there's some that are accessing all services, and then there's others that are only accessing, and there's some that are accessing very few services, whereas there's some that it's like they see primary care and specialty care, but they don't have many inpatient care needs, and they don't see the emergency room as often, as well as some that just see specialty care and like all of the rest of the services are less, and then some that really just seem to be accessing emergency and urgent care, but the other services about the same, and then specialty care less. And it gives us a sense as to ways that we might be able to target care or improve care, or if there's people with unmet needs. This has been hypothesis generating for like, why are there different forms of healthcare service utilization? So we'll get to that. So Christy, you can go to the next slide. And the clusters are pretty similar in size, ranging from 105 to 60. And really, in the all high cluster, it was pretty clear that those individuals were much sicker. And we're not presenting the comorbidity just because we have a short presentation here today. We're not presenting as much about the comorbidities. Part of me wanted to, but then I didn't get tribal approval for that aspect of it. So I'm just sharing about the clusters themselves and the mortality today. But one thing that I did want to point out was that with the all high, that's a lot of visits. And the median number of visits is quite high. And this is not over the entire duration. This is the year of diagnosis and the year following diagnosis. So in the all high category, that's what is that? The like 30 visits within, as a median number of visits within 1 year, versus low, it's 5. So there's just a huge variety in the number of visits. And then that with the emergency care and the urgent care, there is some inpatient utilization, but it's not to the same extent as the all high group, in which, it was 3.5 inpatient days was the median number of days. So, we looked at this and looked at these clusters to see if there were differences in mortality amongst these clusters, and we did find differences in mortality. We used the all low service utilization cluster as the referent, but in comparison to that all low cluster, the relative risk for mortality, and this is the relative risk mortality was about 2.3 times higher, but that was for the rest of the duration of the period. So that's not just for the year of diagnosis and the year following. That's for the remainder of the study period. So, but then no real differences between the other service utilization clusters. So no real differences between the high primary care and specialty care, high specialty care, or high ED or urgent care. So compared to the all low service utilization cluster. So, so, I mean, essentially, and some people might say, did you need a research project to do this, to know this? But that the people that had the greatest healthcare related needs received the most services. We did identify that. But this has been helpful for hypothesis generating in predicting patterns of service utilization. And we want to start looking at things other than just mortality. So we were a little bit hamstrung by our data set in this instance. And I mean, it was a data set that we designed, so it's being hamstrung of our own doing. But we can look at other service utilizations. I will say, you know, there's also kind of a limitation of this, and I don't even know if we have limitations coming next up, but that it seems like once some people are in an assisted living facility, they're receiving a lot of care outside of our services. So that's one of the other things we're hoping to get a little bit more information next time, was to get a better sense as to some more nuanced indicators other than just mortality, and then like 30-day hospital rehospitalization, but just better understanding the other services. So you know, we hope that you did learn a little bit from this. And to know that it's not, in terms of service utilization, it's really not just 2 clusters, seemingly. It seems like there are, at least within our health system, there's 5. And hopefully we can validate these clusters as we expand the time frame and flesh out just any remaining diagnoses that need to be part of the cases. So I don't know if we're taking questions now, Gretchen, or if we take questions later.
Why don't you take 5 minutes?
Okay.
Go ahead. Good presentation. Thank you.
All right.
So put your questions in the chat box.
And thank you all for attending our presentation. So I'll just give it a minute or two.
Okay. Jaedon, I have a question.
Sure.
Your clusters, you came up with those 5 clusters ahead of time? How'd you create those?
So basically the clusters, there was the biostatistician on the project was Carolyn Noonan, and initially she used this gap statistic to start to look at it as to the best number of clusters. But then later on, she did that and it returned 5. And so myself and a neurologist, Jim Galvin, who I don't know if anybody knows the AD8 screener, Alzheimer's Dementia 8 screener. He is a mentor on the project with me. We basically confirmed based on looking at the data that those 5 clusters looked right. But yes, there is some nuance and some liberties that are taken in defining the clusters.